in the near future. So we'll be able to share this information. Just some quick updates and guidelines. If you can, just mute your during the presentation. Just mute your microphone, and we will be having a Q&A, question and answer session at the end of the presentation, and you can use the chat box to answer to ask questions or comments, and I'll try to do my best in moderating the discussion with our speaker today. You will be receiving an email, everyone, that RSVP for our fall lineup. We have a great fall lineup this semester of some great speakers that will be coming up, and we'll be doing this virtually. And you can register an RSVP online when you get that invitation. Our next session will be September 30th from 4 to 5 p.m. Central Time, and we'll have Andrea Graham present designing digital mental health interventions for implementation in healthcare settings. And it's some very interesting work that she's doing in Northwestern University. So with further ado, I want to present our speaker today, Franco Mascayano. Franco is an early career investigator, a doctoral student at the Mailman School of Public Health at Columbia University. I first became aware of Franco's excellent work when he was a master's student at the School of Public Health at the Universidad de Chile many years ago, that we started some collaboration, and I've always been very impressed with the high quality of his work and his dedication for mental health services research. He brings expertise in applied research, particularly in stigma, in mental health services, in global mental health and psychiatric epidemiology. Franco is a star doctoral student. He's been doing and publishing quite a lot of paper in high-ranked journals, and have been conducted studies both in the United States and globally in areas of Latin America and other places. He's part of the On Track New York team, which is a specialized services of coordinated services for first episode psychosis. And he's been doing some incredible presentations and publications with that work. He has a great paper that came out on Psych Services several months ago on disengagement from first episode psychosis services. So today, we're very lucky to have him. He's gonna present an ongoing study called the COVID-19 Healthcare Hero Study. And he's gonna present the rationale, the initial findings, and some implications for policy interventions. As I said, we will have Q&A at the end. And if you have any comments or questions, just put them on the chat, and I will do my best to moderate the discussion as best as we can. So Franco, you can take it away. You'll be able to share your screen with everyone.
Sure.
And I will be here just turning my video, so it facilitates the discussion better. All right?
All righty. So do you guys see my screen?
Yep.
Okay.
Yep.
Fantastic. So let me try to do that.
Excellent.
Perfect. All right. So thank you, Leo, for such a nice introduction. And thank you for having me here today. I'm glad to be part of this seminar. As Leo knows, I'm quite a fan of the work you guys do at Wachu University. So I'm very glad to be here today. So as Leo said, I'm going to be talking about study regarding the effects of the pandemic, the COVID-19 pandemic, on the mental health of a particular population, healthcare workers, including professionals and non-professionals. And for today, I'm going to try to provide the rationale for the study, some initial findings from some selected countries, because this is a global initiative, and try to discuss with you guys implications for policy and intervention by using the data that we are collecting. So here's a brief outline for my presentation. I'm going to start describing the leaders, main institutions, and what we have called discussion cohorts in our project to deal with different challenges that we are facing. Then I'm gonna just go over quickly on the participant countries. We have many participants. We have many countries from different regions, especially Latin America and Europe, but also from Asia and Africa. Brief background, then the methods, some preliminary findings from Chile, Mexico, and Italy, which are the countries that started first the study. And then I'm going to discuss some methodological challenges and, as I said before, implications for policy and intervention. So the study has many people involved, but here I would say are the main leaders. So we have two main PIs, Ruben Alvarado from the University of Chile and Ezra Sasser from Columbia University. And my role in the project is to try to coordinate the different local teams from the different participating countries. And the institutions, logically, the main institutions are University of Chile and Columbia, but also the Pan American Health Organization has been really involved in this initiative from the very beginning, and they have provided very valuable input on almost everything. So now we have made a formal agreement with them, and some of the results that now we have are going to be disseminated through the PAHO website and through different channels that those guys have. So I wanted to note that, but also wanted to show that there are many people involved. I would say over 100 people from over 25 countries are being part of this very large undertaking. And given that the project has so many aspects, so many components, so we have come up with what we have called discussion cores, trying to deal, as I said, with different methodological challenges. So we have a core, for example, on outcomes and exposures or on data analysis, but also we have cores on how to use the data we are collecting to inform the development of interventions at individual and at the institutional or organizational level, and how to connect an EPI study like this with mental health services or mental health services research. So that's one of the things that we've been trying to develop. And I also wanted to note these people that have been working on this project very hard, and some of the slides actually that I'm going to show you today were developed by them. So just wanted to acknowledge their support and work. In terms of participating countries, we have over 25 countries, almost 20 countries collecting data now, and some countries that are it's expected to join. So in Latin America, we have a strong presence, especially in South America. We have like 11 countries. They have started the study or are about to start, like Brazil. And there are countries from Central America, like Costa Rica, Cuba, Panama, that are, we're in conversations with them. And I guess one of the challenges that those people have is that they don't have enough resources. They don't have people, to invest time and energy on study, but we're trying to find a way to get them involved in our study. We also have many countries from Europe, such as Germany, Italy, Spain. Spain and Italy have been very important for the project overall. They've been from the very beginning, and they have enrolled large samples. In Italy, it's over 5,000 people have been enrolled in the study there. And there are countries like France or the UK that we wish that they would join us too. In terms of Africa, we're now trying to expand the study there. One of the PIs, Ezra, he was born in South Africa and he has many connections there. So we recently, enrolled South Africa as one of the sites. But there are other key players like Ghana, that we're expecting, to also have in the study. We have countries in the Middle East now, like Lebanon and Saudi Arabia. We have countries in Asia. One key player is Japan, where they have a well, controlled sample of over, I would say, 1,000 healthcare workers, and they've been following them from the beginning of the pandemic, and now they are joining us. So from the University of Tokyo. So that's we're very glad to have them, on board. And we recently enrolled Australia, and we've been talking to some people in New Zealand, and well, the pandemic is quite different there. So obviously the rationale and the goals of our study, we thought that perhaps, don't make totally sense for a country that, has so few, cases. But the thing is that they said to us recently that they're interested, in joining, especially with the idea of using, the HEROES study to evaluate the interventions they have been implementing. So that's a way that, well, they said it, to connect, AP research with interventions that are, being implemented now. So we also hope to have New Zealand. So in terms of the background, the COVID-19 pandemic, as you probably all know, the effect of the pandemic is way larger and more serious than any pandemic, in the recent years, or recent decades, so it has extreme health, social, and economic impact. And that was actually the rationale when we thought of proposing this study back in March, at the end of March, when we had the first conversations, with Ezra, with Ruben, at the beginning, it was just like a small study, including only Chile and perhaps, Spain and Italy. But after talking to some collaborators that were in different parts of the world, we found an enormous interest, in joining this undertaking. And after a few weeks, we had 15 countries, and then 20 countries. It was, crazy. And I think they all, shared this idea of trying to, evaluate what is happening with this particular population, given that they've been so exposed to get infected, to infect, their families or their close ones, So we thought that doing a study, particularly with this people, could be, useful. It could be informative for the health sector in general, because the disruption of healthcare system is being enormous in most countries. We know from previous pandemics, like the MERS pandemic, the Ebola pandemic, that usually this population suffers an enormous, emotional burden from the pandemic, from being, there in different health care, settings. And we know that those negative effects could last over time. And that's why we thought that not only cross-sectional evaluation was needed, but also a prospective longitudinal assessment at different time points. So I said that already. And we also thought that we had to try to enroll countries, low and middle income countries, because probably this massive disruption of, social and health system would be larger in those countries. And now we see that the epicenter of the pandemic is Latin America, and it's been terrible in countries such as Peru, Brazil. We kind of saw that in March, back in March, April. So we put a lot of effort to talk the people we knew in those countries and trying to get them on board. And we also thought that that we had to find a way to take into account the nature and the extent of the health response, such as deployment, increased workload, and that was the rationale for some of the items, ad hoc items that we end up, including in our questionnaire. And one of the challenges that we are seeing now is that we have to consider that the countries are at different phase of the pandemic, and they also enter in the study at different time points. So all that has been something that we've been discussing in the data analysis group, and we're still thinking about it, but we know that we have to use the data that we are collecting, but also get data from other sources, to have a clear, full picture of what's been happening in all these countries. So in terms of the main goal, it's quite broad, it's quite general, but obviously we have several specific goals. But in terms of the main goal is that the HEROES study is aimed to describe, examine, and evaluate the impact of the COVID-19 pandemic on mental health and related social and psychological factors among workers at different health services, different health facilities, not only hospitals, not only emergency services, but also primary care clinics, and even residential, facilities or social facilities, because we realized when we were starting the study that in some countries, those places were receiving, people with COVID-19. So we decided to include that in our questionnaire, and now we have an item, listing all the kinds of, health facilities where this population could work at. So in terms of the study design, as I said, this is a prospective study, a cohort study in particular. We are aiming to enroll over 35,000, participants. Already 25,000 have responded, at least have agreed to respond the survey. So we've been doing okay in terms of sample size, but not as good in terms of response rates as I'm going to show you in a minute. We're including a baseline assessment, which most countries are doing now or have already completed, plus follow-ups, I would say 3 to 4 months, 6 and 12 months. And depending on funding, depending on several factors, I guess, we would like to continue, this study over time. But we need to get a grant, so we are, working on it. We are using an online survey, including standardized measures such as the GHQ-12 for depressive and anxiety symptoms, and the PHQ-9 for depression in particular, but also a few items from the Columbia Suicide Scale. And we came up with several ad hoc questions on factors at the workplace, fears and concerns about the pandemic, etc. So in terms of inclusion and exclusion criteria, our inclusion criteria is quite broad. It's just, to be of legal age, which varies, across countries, and to be working in a health facility. In some places like Italy and Spain, when they were like the epicenter of the pandemic, almost all the healthcare workers were, seeing people with COVID-19 or suspected to have COVID-19. So we decided to include all of them, everybody. And in terms of exclusion criteria, we don't have formal exclusion criteria. We just, we're just aware that people that cannot be reached by, cell phone or laptop or any, digital device won't be part of the study. But given that now we are trying to also include countries from low and middle income countries in Africa and Asia, we are thinking of ways to allow them, to be part of the study. But I don't know, we're still thinking about it. But it hasn't been a problem for Latin America and Europe for now, at least. So this is one of the, I would say, most complicated, things about this study, and it refers to sampling and recruitment. Why it's complicated? Because we have to do everything online. It's difficult to just go to the health facilities and trying to talk to people, because in some cases they are just super overwhelmed, super busy, so it's been difficult. But our main approach has been to get lists of emails and phone numbers from different places, from Ministry of Health, from health facilities, from professional associations, from unions, to try to get a sense of what our denominator is, what our target population is. And that's been a way, a formal way to have a sense of it. However, it's been difficult because for some particular groups, like non-professional, people that provide, cleaning services or food services, sometimes they don't work at a particular health facility. They work at different places. They don't use emails, or the emails they are on those lists are not up to date, so it's been hard. But that's our main approach. But we have also tried to disseminate the survey link through some closed groups on Facebook and WhatsApp. But we've been a little bit hesitated about that, because we don't want the survey, the link to just go viral and just lose track, not get a sense of who are, responding the survey. And the main idea, the whole idea, I would say, is trying to identify potential denominators. And it's been hard. We are still thinking about it. In my view, the easiest way to go is to just list particular, health facilities, like the names of the hospitals and stuff like that. But it's also complicated because some participants don't want to be identified that they work a particular place. So those are, challenges that we are, discussing. So in terms of the instrument, I have already said that we came up with this, questionnaire, including the standard measures, but also ad hoc questions on several factors that, based on a literature review that we did, and also based on input that we got from people from the working at the front lines, we came up with ad hoc questions, for example, on formal and informal support that these participants have been receiving, and key elements like prior physical and mental conditions, because in Psychiatric, we all know that prior conditions usually explain a lot, so we're trying to explore that as best as we can, considering that there are some biases that could arise there, like memory bias, but it's better than nothing, I would say, because we don't have a real baseline, if you will. We don't have a measure or assessment before the pandemic started, so we're trying to emulate and to get a sense of that information by using those items. And we recently included a measure on PTSD, because we think that that would be, especially in the future, our main outcome, because it's hard to distinguish between like an accurate reaction to a stress from actual PTSD. So at baseline, we included items on acute stress, and for the follow-ups, we are using PTSD, a PTSD measure based on the DSM-5. So in terms of preliminary findings, I just selected a few, findings that I find, quite informative and could be used for different purposes. And that's actually what we are planning on doing with PAHO and other, agencies. But in terms of in terms of the recruitment, we have enrolled over 25,000 participants, from all these countries. Italy and Mexico are the countries with most participants, especially Italy, where they try to do like a national sampling, and that's one of our best sites, I would say. Samples, though, include mainly physicians and nurses, and we've been facing, different, problems to engage non-professionals, as I said before. Right now, just after doing some descriptive analysis, we got a sense that in general there is a high frequency of depressive and anxiety symptoms, but there are other areas that is being quite interesting from a policy perspective, like people in Mexico, people in Italy, actually people in Chile and also there is a lack of trust in the actions that the government and health authorities, in particular, health facilities, have been, taken. So social justice or social trust, those dimensions, I think, or at least my understanding, have not been really explored in previous pandemics. So we are thinking that those are factors that we would like to examine further, and and see how those factors are related to our main outcomes. So in terms of Chile and Mexico, and I decided to put these two countries together because they started, in April, almost at the same time, and I think in June, because now they have enrolled more people. Now in Mexico have over 3,000, but at that time, like a month after starting the recruitment, they have enrolled over 1,000 people in Mexico, close to 800 people in Chile. Most of them have completed the survey, which is good, and those numbers are, usually, acceptable in psychiatry research. However, the response rates have not been good. And here, I mean, we can discuss this, right? Because I don't think that, like previous standards in terms of response rate really apply to this particular situation. So some people have said in very, respectful and prestigious journals like JAMA or The Lancet that response rates like this are not that bad and are expected, given the huge disruption of the pandemic. However, in general, response rate for online surveys should be around 30 to 50%. So it's, we are thinking of ways to improve this, but just wanted to know that and be really honest that those are the response rates that more or less we are getting now. So in terms of the type of healthcare workers that are part of the study, as I said before, mainly physicians and nurses. Same thing you'll see in Italy. This item, the item we have on PPE, that was promoted, I would say strongly. The PAHO strongly, suggested to include items on this and see the potential, associations between, the lack of PPE and mental health outcomes. And here you can see that, at least in Mexico, most of the sample, most of the participants thought that the PPE they had were, definitely insufficient. And in Chile, it wasn't, entirely like that, but I think, at least a part of the sample also thought that way. And in terms of being stigmatized, and that's something that I would say in previous studies, on previous pandemics, also has not been, totally examined. And in Mexico, many of the participants, said that they were strongly, they've been, quite stigmatized, for just being a healthcare worker, just for being exposed to people, that have the virus. And this is another, item that I thought you may find, interesting, and it refers to what extent the participants think that or trust, the decisions, by the government or by the people in charge, their workplace. And in general, in both places, in both countries, people just don't trust. And we were told that that some of the participants, just they were just not in good terms, with their bosses. They were not opening emails that come from, health authorities in their, workplaces, so there's clear like a problem there, and they just don't feel that people in charge are doing the right thing, and well, you can also see that here in the US, I guess. And in terms of, mental health outcomes, in general, for both the GHQ-12 and the PHQ-9, people scored, above the cutoff score for both places, which is a little bit different for Chile and for Mexico. And in general, people, the participants, reported anxiety and depressive symptoms above the, I would say, the normal. In terms of Italy, at the time they conducted this analysis, they have enrolled over 1,200, healthcare workers. Most of them also had completed the questionnaire, and the response rates in Italy were a little bit better, and I think they now have even better, figures. So as I said, I'm quite proud of Italy. They've been doing fantastic. But in terms of the sample, again, I mean, there is definitely a overrepresentation of medical doctors, nurses, and in this case, occupational therapists. So there are other, non-professional groups that are not part of the sample, even that was one of our goals, at the beginning. So we are, again, discussing how we could engage those people in the study. In terms of the PPE, here you see some differences, and most of the participants were actually okay with the, PPE they had. But still, there's almost 30% of the sample that thought that they were somewhat insufficient. In this case, again, there is a large proportion of the sample that scored, quite high on the GHQ-12. And in terms of the PHQ-9, these results are actually a little bit concerning because, almost 20% of the sample, scored having like between a moderate depression and a severe depression. And they had a comparison, and they put this in the slide, that in a study from 2017, the percentage of people presenting between a moderate and severe depression was way lower than what we are reporting here, and it was kind of the same or a similar sample. So obviously these results are concerning, and our collaborators in Italy are thinking of ways to communicate this to local stakeholders and the participants themselves. In terms of methodological challenges, I would say we have faced many. So I just listed here what I thought have been the main challenges. So the first one being how to identify denominators, how to estimate response rates, like the real response rate, I would say, because in some studies they just use this approach that they have a way to identify the participant open the email, and that's what they say it's like a way to see how many received the survey link, how many opened the email, etc., etc. But we have used a different approach, which we think is more rigorous. Just try to get a sense of the total population, in particular, health facilities. But it's been complicated, especially in some countries where there are no registry of they don't have that information. So we've been trying to kind of create databases with emails and phone numbers and stuff like that. The second challenge that I wanted to note is that there is a lack of representativeness for some groups, especially non-professionals. We have tried, to connect with unions and like non-professional associations, but it hasn't been easy. They sometimes don't have that information. They don't know how many people are part of their institution, and sometimes they are not willing to share that information with researchers. So it's been complicated. Another challenge refers to having countries at different phases of the pandemic and entering at different times, and that's kind of part of the nature of the pandemic, because now the epicenter is Latin America, but in 2 months, in 2 months could be Africa and be Asia. It's quite dynamic, so it's hard to take that into account, but we are trying. And we haven't done any comparisons across countries, but we would like to. So there is information that we are getting from other sources, such as when a particular country decided to impose like a quarantine or stuff like that, or specific, social distancing, interventions at the governmental level. So we think that that's been well documented in most countries. So we are planning on using that information when running analysis. In terms of implications for policy and intervention, I think even if even all the challenges that I have noted, so far we have been able, to construct this quite strong, and large network across countries. And many of the people that are part of the study are well connected with, people in charge of mental health policies, of implementation of mental health policies in all these countries, such as chief of or heads of mental health departments and Ministry of Health, or people that are basically policymakers. So they are quite eager to hear from us. And one example are the people at PAHO, which recently has asked us, to share some preliminary results because they are working on a policy document that they're going to publish, next week. So that's an example, I think, that how this study is informing policy for entire region, which is Latin America and the Caribbean. Results we hope will be also disseminated among stakeholders, especially policymakers at different, agencies. As I said before, our collaborators are well connected. So we think that there are going to be different ways to disseminate the results, not just publishing a paper. And some health facilities, some particular hospitals, and primary care clinics have expressed, interest in getting like info about the, healthcare workers that they work there, So we're thinking of ways to distinguish that, but as I said before, it's a little bit tricky because some participants don't want to be identified, but that they work at a particular place. But those are things that we are discussing right now. And in terms of interventions, we have two groups, as I showed in the beginning, about how we use the information we have for informing the development of individual and organizational level interventions, and they're working on it, and there are some proposals, and those interventions are going to include, I hope, digital-based interventions in terms of the individual level interventions, but also how to change the organization of a particular health facility in terms of the availability of PPE, the way that the healthcare staff is communicated to each other, and how the decisions are shared from health authorities and stuff like that. But we have also been told that some countries like some countries like New Zealand are trying to to use the information collected by HEROES to evaluate the impact of some interventions and some actions that they've been taking from the beginning of the pandemic. So that's another way that we think the study could inform intervention. And I think it would be ideal. I don't think that's possible, feasible in all countries, but we would like to keep providing data for health facilities as long as they find it useful and they could use it for different purposes. So that's another area that we would like to develop. So I think that was it. My email is there. I can share more information about the study upon request, and happy to have a conversation with those that are interested in our work. Thank you.
Excellent, Franco. Thank you so much for the presentation, for this great effort, global effort for addressing the mental health needs of healthcare workers through this pandemic. So there's been several questions in the chat. I'm just gonna make sure I can cover them here. There we go. So Duni Hansel had a question earlier on when you presented sort of the response rates. Were those for people who completed the baseline the baseline surveys?
Yep.
The low response rates are for those who enter and actually completed those baseline surveys. Yeah.
Right.
Is data also coming? Are you starting to get information from the 6 months or follow-ups at this point?
So I think Spain and Italy are about to start the first follow-up, and then Chile and Mexico. But we're also thinking of perhaps enroll more people, like new people, in some countries and trying to ensure like better response rates, because I think now could be, you know, easier to just kind of identify some health facilities, for example, from areas or regions with, you know, large numbers of people with COVID-19 versus regions with lower numbers, and just identify, you know, some hospitals and trying to enroll as many people as we can, because that wasn't like our original, you know, approach. And we think that that way could be like more rigorous, and we could, you know, do it better in terms of recruitment. But there are something that I think I have to mention, that we came up with this idea, you know, in March. We didn't know much about how to do it, you know, and in sites like Italy and Spain, it was terrible. I mean, I was actually, you know, doubtful that we could actually work, you know. So obviously our recruitment, you know, approach could be improved, and that's something that we are, you know, working on.
Thank you. And actually related to that, Greg Gross has a question here. Did you guys offer any benefits, any other incentives for people to participate, or resources to assist in the participation rate and hopefully increase the response rate? Was that part of the plan, or yeah.
I would say that's part of the plan, as long as we get some money, because we have none right now, and so that's one complication. And another complication is that in some countries, the local RVs are not entirely okay with that. I mean, it's fine in Europe and Australia, you know, they are quite familiar with that approach. But in Chile, for example, or Italy, you know, that they raise questions that they don't want, you know, that you use money to engage people, you know, so they're quite old-fashioned, or, you know, maybe it's a cultural thing, I don't know. Mm-hmm. But that's a negotiation that we need to have with the local RVs. But yeah, it's we would like to do that. We think that you know, could make a difference.
Yeah, and I think it's a very important question, and very difficult given all the places you guys are doing this. One thing that has come up in other studies is there's anything that you can provide back to them in terms of, you know, information of the data that's being collected, results, potential, you know, resources, local resources they can go to, or any intervention that comes up as an opportunity, like for increasing the incentive to participate as well.
Right.
Greg also has two other questions. One, and I think you covered this at the beginning, but I may have missed it. It's sort of what is the definition of the healthcare worker, of the population you guys are trying to capture here? Because there's a diversity of different healthcare workers here. Right. And also, is there any theoretical, conceptual framework that's informing or guiding the research?
Regarding the first question, I think I said it before, but I can say it again. So we try to enroll all the people working at any kind of health facility, including both professional and non-professional, you know, groups. That was our idea in the beginning. However, it's been difficult, you know, to engage non-professional, and nurses and physicians, as you saw in my slides, are, you know, the main groups, you know, in the sample right now. So that's another thing that we would like to improve somehow. And we think that through unions maybe, but you need people like inside. Mm-hmm. It's not just about money in that case. You know, you need them, you know, to trust you. You know, they need to find a value of in what you're doing. And I guess we haven't been able, you know, to come up with a good strategy for those groups, but that's the way it is. In terms of any theoretical or conceptual frameworks, I mean, to be totally honest, no. We just wanted to include almost, you know, everybody. And at that time, we heard that there were other 2 studies, you know, including healthcare workers, but focus on, the general population. One from Harvard, another one from the UK. I haven't heard from them now, so I don't know if they're still doing it. But at that point, we heard that they wanted to focus on physicians and nurses. Mm. So we thought, okay, we're going to try to distinguish from them, and trying to cover, everybody, and with the rationale of that many of these non-professional staff are usually not well paid. They're quite exposed, to get the virus, anyway, and they don't receive the same benefits and recognition of, physicians and nurses, so that it was more like a human rights kind of, perspective rather than, scientific one.
Got it. And I guess you guys are going to continue sort of the study will evolve in a sense that as you're collecting 6, as you mentioned, for 6 and 12, you examine more PTSD. I wonder whether there's also opportunities for examining things like coping strategies that people are using, or trust to government, trust to healthcare facility, trust around community. There's a lot of different things here that I think could be included as well.
Yeah, we have some questions on resilience, and personal growth. Some of our people have said that personal growth or post-traumatic personal growth could be like something interesting to look at. I'm personally not really familiar with those, fields, but they sound important. So we would like to include more. The problem is that the questionnaire, as it is now, it takes like 15 to 16 minutes to complete. So it's a little bit long. We are trying to make it shorter, but it's not easy, because every time that we have a conversation about this, people, come up with new ideas, and let's ask about other stuff. Everything is important, and
of
that
course.
kind of things.
And actually related to instrument Lin Jun, if I got correctly, I have a great question here on sort of the cultural and language issues that may come up, and how that may how has your study dealing with the reliability and validity of instruments across cultural contexts? So how has that been play a role in the design of the study?
Yeah, no, that's a great question. So one of the rationale that we had, in the beginning was that, okay, let's try to use, measures that are validated and adapted almost everywhere, and that's the case for the GHQ-12 and the PHQ-9. They are already validated in most countries. That's my understanding. So we have the information about about the scores, about the previous adaptations, on those two measures. So let's say we took that for granted, but for the ad hoc questions, we kind of did at least a cultural, adaptation, because we were working together with different, countries from the very beginning, and having, many calls going over each item, and identifying those, cultural, meanings, if you will, that differ, across countries. So we kind of did that, but in addition, some countries are actually conducting like more formal adaptations of the questionnaire. So it's been something that has been developed like in parallel, I would say. Mm-hmm. But this study is such a large, initiative that even for me, sometimes I get lost. So then I find out that, someone in India is doing something that could be, useful for the entire project. So then I try to talk to that person, and so on. And so, so that's one of the related initiatives that some people have been conducting.
Got it. And I wonder, are they, and please, if anyone has any other question, please use the chat box as well. This has been great questions. I often wonder in initiatives like this is an opportunity to create sort of a global surveillance system for mental health issues, in particular in situations like this, whether these are examples of creating that infrastructure for the globe. Because we don't have good surveillance systems of mental health around the globe. And this gives an opportunity to test some ideas, the infrastructure that's needed, the partnerships that may be created. So as your group thought about that, in the larger scheme of themes of what you're doing, yeah.
No, definitely. We have discussed that. I think we would love to do something like that, and other stuff that we've been discussing. However, without funding, it's just really hard. I mean, we are barely keeping things up right now. So I think we're going to apply for a poverty grant or something like that, but we need to get money, because we hope to get hopefully some financial support from some governments, perhaps, but you need like a big grant, to keep this going. And without that, it's hard, to envision, something like what you are saying, even though I find it quite interesting and feasible. That's the thing with this network, is that it's composed of people that are super close, to key stakeholders. So they know the people, they have the power, we don't have the money, but we have the connections, So yeah, this could be an amazing opportunity to do something like that. But we need some funding. That's what I can say now.
For sure. No, I think a foundation fund, government funding will be critical for something like that. Another component is, I think, the network that you guys have created and the foundations of the work. It's a really interesting network. So some type of network analysis of all in every country, who's connecting the dots here, I think will be very important, because that's sort of the infrastructure for doing this type of services research and epi research across the globe, particularly in a pandemic and with everything that's happening. So any other question? We're running almost to the end of the hour. I think those are all the questions that we have. All right. So I would like to thank you, Franco, for our excellent presentation. This is an initiative that you called me one day in March looking for people in Puerto Rico, which was great to see. And it's been very amazing to see the work that you guys are doing throughout the world and trying to do this with all the challenges that you mentioned. So we look forward to seeing more of this and seeing what comes out of these efforts and studies. As I mentioned, we will continue our seminar series. Our next seminar will be on September 30th from 4 to 5 p.m. Central Time. And as I mentioned, Andrea Graham will be presenting on designing digital mental health interventions for implementation in healthcare settings. And we look forward to having someone. We will be sending the schedule for the fall, as well as specific invitations for it. So Franco, it's great to see you. Great to see everyone here. Please take care, and we'll see you in our next seminar series. All right. Thank you so much.
Bye.
Bye.